So if you look really closely at the medical term for artery, the high-pressure highway that keeps you alive,
Yeah.
you'll actually find this wild 1,400-year-old mistake baked right into the literal translation,
Yeah, it literally means air holder or like an air duct.
which is just crazy.
Yeah.
But welcome to the deep dive.
Yeah.
We are unpacking a stack of medical terminology sources today, decoding the language of our blood vessels.
Right.
Specifically, we're looking at the roots arterio, phlebo, and veno. And we're starting with this phenomenal contradiction. The very word we use for a vital blood vessel translates to a tube that holds air.
And, it wasn't just a quirky linguistic accident either. Like ancient anatomists and early dissectors, when they were examining human cadavers, they would frequently find these thick-walled vessels completely empty.
Right, because after death, the blood drains away.
Exactly. It pools down into the lower, thinner-walled vessels. So looking at these totally empty, robust tubes, they made what was honestly a perfectly logical but completely incorrect assumption.
They assumed they carried breath.
Right. They thought they normally carried breath or pneuma instead of blood.
And we're talking about a fundamental misunderstanding of the human body that got permanently locked into the vocabulary of medicine. So today, for you listening, our mission is to untangle all of this.
It's a big knot to untangle, too.
It really is. We want to look at how this ancient anatomical mistake governed medicine for centuries, how it was finally overthrown, and why getting these specific vessel words right in a modern hospital is quite literally a matter of life and death.
Yeah, because to understand how we talk about the body today, you really have to look at the linguistic collision that we inherited. The medical vocabulary for blood vessels isn't, one clean, cohesive system designed by a single committee.
No, it's a mess.
It is. It's a fusion of two ancient languages basically competing with each other.
So we have three main combining forms doing the heavy lifting in our sources. We use arterio for artery, which comes straight from that Greek word arteria. But when it comes to the veins, we suddenly have two entirely separate word roots. We have phlebo, coming from the Greek word phleps, and we have veno, coming from the Latin word vena.
Both meaning the exact same thing.
Right, both just mean vein.
Yeah.
So why didn't medicine just pick one?
Well, it comes down to a historic tug-of-war between academic standardization on one hand and just stubborn clinical habit on the other.
Okay, how so?
So English medicine was largely inherited through Renaissance-era scholarly Latin, but that Latin was built on top of a massive Greek foundation.
Right.
When anatomists in the late 19th and early 20th centuries sat down to create a stable international nomenclature, things like the Terminologia Anatomica, they decided the formal, official map of the body should be pure Latin.
So the physical structures themselves became Latin.
Exactly. But the doctors who were actually treating patients out in the clinics, they did not want to change their terminology.
Oh, of course not.
Right. Clinical medicine refused to purge its Greek layer. Doctors were used to the Greek diagnostic terms. So instead of choosing just one root for vein, English medicine just kept both.
And they assigned them entirely by convention.
Yeah. You have a Latin root for the anatomical structure, and often a Greek root for the disease affecting that structure.
Which creates a total headache for anyone trying to decipher medical charts. I mean, you have to recognize two completely different roots for a single physical pipe in the body.
It is definitely a hurdle for learners.
But that brings up an even bigger issue. If I go out and ask someone on the street to define the difference between an artery and a vein, almost everyone will immediately talk about oxygen.
Oh, 100%.
Right. They'll say, well, arteries carry oxygen-rich, red blood, and veins carry oxygen-poor, blue blood. And you look at your wrist, the veins look blue, so it feels completely intuitive.
It feels intuitive, but it is entirely false.
Completely false.
Yeah. The strict anatomical definition of these vessels has absolutely nothing to do with their oxygen content. It is 100% about direction.
Direction. Okay, let's clarify this for the listeners.
An artery is simply a vessel that carries blood away from the heart. A vein is a vessel that carries blood toward the heart.
Wait, hold on. What about when blood goes to the lungs? Because that has to break your rule, right?
Right.
You are sending oxygen-poor blood out to the lungs to get oxygenated.
The pulmonary circuit actually proves the rule perfectly.
Oh, really?
Yeah. Think about the vessel leaving the right side of the heart. It's carrying deoxygenated dark red blood out to the lungs. It is traveling away from the heart.
Okay.
Therefore, it is the pulmonary artery, even though it's deoxygenated. And the vessels carrying that freshly oxygenated bright red blood back from the lungs to the left side of the heart, they're traveling toward the hub.
So they are the pulmonary veins.
Exactly. If you try to define the vessels by oxygen, the pulmonary circuit completely shatters your rule. But if you define them by direction, the logic holds flawlessly.
Okay, let's unpack this with an analogy to help you visualize it. Think of the heart as the central transit hub, like a massive train station.
I like that.
It absolutely does not matter what cargo is loaded on the train cars, whether it's coal, passengers, oxygen, whatever. If the track leaves the station, it is an artery. If the track is returning to the station, it is a vein.
And that strict one-way trip actually physically dictates the architecture of the vessels themselves.
Right, because in anatomy, form always follows function.
Always. So arteries are leaving the station, meaning they receive blood under immense pulsing pressure directly from the contraction of the heart.
It's a violent environment.
Very. To survive that, arteries are built with thick, elastic, highly muscular walls. They literally have to expand and recoil to withstand and kind of smooth out that high-pressure wave with every single heartbeat.
But by the time that blood travels all the way out to, say, a capillary bed in your foot and turns around to make the return trip, that initial pulsing pressure from the heart is basically gone, isn't it?
Oh, the pressure drops dramatically. Veins are returning blood to the heart under very, very low pressure. They don't need those thick, muscular shock absorbers at all.
So they have thinner walls.
Much thinner. But they face a totally different, severe engineering problem, which is gravity.
Right, fighting gravity.
Yeah. Think about that blood in your feet. It has to climb all the way up your legs, fighting gravity the whole way with almost zero pressure pushing it from behind.
So how does it physically get back up to the chest? I mean, what's doing the pushing?
It's a brilliant evolutionary workaround. First, the veins rely on the skeletal muscles surrounding them. Every time you walk, or flex your calf, or even just shift your weight, your muscles physically squeeze the veins, squishing the blood upward.
Wow.
Yeah, it's known as the skeletal muscle pump, or a second heart.
But what stops it from falling back down between steps?
That's the second part. To prevent the blood from just falling right back down into your feet when the muscle relaxes, veins are equipped with internal one-way valves.
And arteries don't have these.
Arteries don't need them. They have high pressure driving the flow forward. Veins rely on these valves to catch the blood, locking it in place step by step as it climbs back up to the chest.
That is fascinating. And because of these totally different jobs, we get a massive counterintuitive difference in blood volume.
Yes.
Because, look, here's where it gets really interesting for you as a learner. In every medical drama on television, the arteries get all the cinematic glory.
Right. Oh, absolutely. The high-pressure emergency.
Exactly. Pulsing blood, alarms going off.
Yeah.
But the humble vein is actually doing the heavy lifting in the background. According to the sources, veins hold roughly 60 to 70% of your total blood volume at any given moment.
Yeah, because their walls are thinner and highly distensible, which just means they can easily stretch out like a water balloon. Veins function as what we call capacitance vessels.
Capacitance vessels.
Right. They serve as a massive low-pressure reservoir for the body's blood. Arteries are just simply too rigid and thick to hold that kind of volume.
So we have established the modern reality here. It's a closed loop, driven by a central pump, defined strictly by direction, with totally different architectural plumbing for the outbound and inbound trips.
That's the modern view.
But if it is one continuous loop, how did ancient medicine get it so spectacularly wrong for 14 centuries?
Well, we have to look at how they conceptually viewed the human body back then. In roughly 300 BCE, a Greek physician named Praxagoras of Kos was actually the first to systematically observe that these were two distinct networks.
Sure.
He stopped treating all vessels as just one generic category, but the true architectural era came later, from Galen of Pergamon in the 2nd century CE.
And Galen was an absolute giant in ancient medicine. His writings were treated as unquestionable medical law for generations.
He was the undisputed authority, but Galen rarely dissected humans due to cultural and religious taboos at the time. He worked mostly on animals, like Barbary macaques and pigs.
Oh, wow. Okay.
And he built a model that concluded arteries and veins were two completely separate, largely disconnected plumbing systems. They absolutely did not form a loop.
So what did you think they were doing?
According to Galen's model, venous blood was actually manufactured in the liver, synthesized directly from the food you digested.
The liver.
Yeah, the liver. This dark blood then flowed outward through the veins to nourish the tissues, where it was essentially consumed. It was a one-way, ebbing and flowing system that constantly had to be restocked by eating meals.
So he literally thought The body was acting like a furnace, just constantly burning up venous blood that the liver had to keep manufacturing from scratch.
That was the idea, yeah.
What about the arteries then?
Arterial blood, in his model, was made completely separately in the heart. And this is where that air holder root, arterio, comes back into play.
Oh.
Galen believed arterial blood carried vital spirits and innate heat to the body, which was created by mixing blood with air drawn in from the lungs. So you have two completely different fluids, manufactured in two different organs, doing two different jobs, and neither of them circulating in a loop.
It is wild to think this was the accepted, unquestionable truth until the Renaissance. I mean, it wasn't until 1628 that an English physician named William Harvey published a short treatise called De Motu Cordis on the motion of the heart that finally destroyed Galen's model.
And Harvey didn't just propose a new theory. He physically proved the closed loop using incredibly elegant ligature experiments.
Okay, how did he do that?
He would tie a tourniquet on a farmhand's forearm, tying it just tight enough to block the superficial veins, but loose enough to let the deeper arteries keep pumping blood down into the arm.
So the blood could get into the arm, but it couldn't get back out.
Exactly. He watched as the veins on the surface swelled up enormously. But more importantly, he could physically see the blood pooling on one side of those internal one-way valves.
The ones we talked about earlier.
Right. They look like little knots under the skin. He would press his finger on a vein and try to push the blood backward away from the heart, but the valve would catch it. It visually proved that the valves force blood in only one direction, back to the heart.
Which proved the venous and arterial blood were the exact same fluid, just traveling on different legs of a single journey.
Yeah, it was revolutionary.
But Harvey's real genius, though, was bringing math into the operating theater. Our sources highlight this. He didn't just look at the veins. He calculated the volume.
Yes, this is my favorite part.
It's so clever. He measured the capacity of a heart's ventricle, say, roughly 2 ounces of blood. He multiplied that by the average number of heartbeats in a minute, and then multiplied that by 60 minutes in an hour.
It was an arithmetic proof that completely shattered Galen's idea of the liver constantly making new blood. Harvey's calculations showed that the heart pumped a volume of blood in a single hour that weighed significantly more than the entire human body.
It's like looking at a massive decorative water fountain in a city park. You do the math. If water is blasting out of the top at 20 gallons a minute, there is no way a hidden underground hose is endlessly supplying brand new water from the city reservoir.
Right, it would flood the city.
Exactly. The fountain has to be recirculating the same water in a closed loop. The liver couldn't possibly synthesize 3 times a man's body weight in blood from a single meal. The heart had to be recirculating it.
It was a radical break from tradition. It was one of the earliest examples in medical history of a purely quantitative mathematical argument settling an anatomical debate. And this was decades before microscopes were powerful enough to actually let scientists see the tiny connections between the arteries and the veins.
It's incredible. But, this isn't just historical trivia. Taking 1,400 years to figure out this directional loop had severe, deadly consequences.
Oh, absolutely.
Not understanding what a vein actually does killed a staggering number of people.
The most consequential, widespread misuse of this misunderstanding was therapeutic bloodletting. Right.
For over 2 millennia, standard Western medicine was dominated by humoral theory, the belief that disease was caused by an imbalance in the body's fluids, or humors. Because physicians didn't understand that veins were just a return highway in a closed, pressurized loop, they genuinely thought you could vent a localized illness by deliberately slicing open a vein and draining off the stagnant, quote-unquote, bad blood.
The reality of this practice is visceral and honestly horrifying when you look at the historical records. Take George Washington, for example.
That's a classic case.
In December 1799, he developed a severe throat infection. Modern historians suspect it was acute epiglottitis. Over a period of roughly 12 hours, his highly respected top-tier physicians drained an estimated 40% or more of his total blood volume.
40%.
For multiple bloodletting sessions.
They systematically bled him dry, trying to clear an infection. It is widely regarded today as having severely hastened, if not directly caused, his death from shock and oxygen deprivation. It's just a stark, tragic case study of how an intervention rooted in the phlebo system, a vein-based intervention, can become a weapon when the doctor fundamentally misunderstands the anatomical reality of what a vein does.
Absolutely.
So how does this ancient misunderstanding of venous pressure translate to a modern emergency room? Obviously, we aren't doing humeral bloodletting anymore. But getting the difference right between an artery and a vein is still absolutely vital for patient safety today.
It is. Think about just the mechanics of inserting a needle. A venipuncture, inserting a needle into a vein to draw blood or establish an IV line, is a routine, low-risk procedure.
Right, they do it all the time.
Because veins are low pressure, they are structurally close to the surface of the skin. Because the pressure is low, they stop bleeding relatively quickly with just a little manual compression.
But if a nurse or doctor accidentally hits an artery instead of a vein, the physics of the situation change instantly.
It becomes a completely different ballgame because arteries are carrying the direct, high-pressure pulsing force of the left ventricle. Puncturing one creates a massive bleeding risk.
It's not just a little prick.
No, the blood doesn't ooze, it spurts. It requires significant, prolonged pressure to stop. And if it's not stopped properly, it can easily create a hidden pocket of bleeding called a hematoma that compresses the surrounding nerves and compromises the circulation to the entire limb.
That pressure difference also makes medication errors terrifying. The sources talk about the route of administration abbreviations. 4 versus IA.
Yes, IV stands for intravenous, into the vein. IA stands for intra-arterial, into the artery.
If you confuse those two letters on a patient's chart, what actually happens inside the body?
The cellular mechanics of that error are devastating. Many drugs are chemically caustic. They're specifically formulated to be injected into the venous system because the venous flow goes into an expanding network.
Right, moving toward the heart.
Exactly. It travels from smaller veins into the massive vena cava and dumps directly into the massive mixing chamber of the heart. This instantly dilutes the caustic drug into the body's total blood volume.
So the drug gets heavily watered down before it hits any delicate tissues.
Right. But what happens if you push that same drug into an artery? Arterial flow moves in the opposite direction into a narrowing network.
Oh, wow.
If you mistakenly inject an undiluted caustic drug directly into an artery, the flow pushes it straight down into the microscopic capillary bed of that specific limb. The high-concentration drug gets trapped in the delicate tissues of the hand or foot, destroying the cells and causing massive tissue necrosis.
Which can frequently lead to amputation, just from a mixed-up abbreviation.
Exactly. It's incredibly dangerous.
So we have these Greek and Latin roots, arterio, phlebo, veno. How do they actually stack together when things go wrong in the body? Let's trace a real clinical scenario using the vocabulary. Let's look at deep vein thrombosis, or DVT, that economy class syndrome you get from sitting too long on an airplane.
It's a great example to use. Remember that veins rely on the skeletal muscle pump to keep blood moving upward. If you are crammed in an airplane seat for 12 hours, you aren't moving your legs.
The muscles aren't squeezing.
Right. The blood in the deep venous structures begins to pool, and pooling blood loves to clot. That clot is called a thrombus, which gives us the root thrombo.
And if that pooled, clotted area becomes inflamed and painful, this is where clinical medicine reverts to the Greek root. We don't call it venitis. We combine thrombo, phlebo for vein, and elidinitis for inflammation, giving us thrombophlebitis.
Right. Now, the real danger is if a piece of that clot breaks off, it becomes an embolus. It travels up the low-pressure venous highway, moving through larger and larger vessels, passing into the cardio, the heart, and gets pumped right back out into the pulmonary arterial circuit.
So it's traveling through a narrowing network again, heading into the lungs.
And eventually, the vessel becomes too small for the clot to pass through. It wedges into place, blocking blood flow to the lung tissue. This is a pulmonary embolism, a direct and life-threatening consequence of the low-pressure venous environment.
Now, if a doctor is looking at a scan of that clot, but isn't sure exactly which specific vessel it's lodged in, they can use vessel-neutral terms, right? Like angio from Greek or vaso from Latin.
Yeah, those just mean vessel in general, giving us words like angiogram or vasodilation.
And we definitely have to mention the microscopic structures where the arterial outbound train literally becomes the venous inbound train.
The capillaries.
Yes, the capillaries. I love this linguistic detail. The word capillary doesn't even use a Greek or Latin combining form for vessel.
No, it doesn't.
It is derived from the Latin word capillaris, which means hair-like, because of its microscopic, incredibly thin diameter. It is just a fantastic visual for you to anchor the anatomy.
It perfectly illustrates how wonderfully descriptive ancient medical language tried to be, even when the underlying physiology was still a total mystery to them.
It really does. So to bring this all together for you, we started our deep dive with a linguistic collision. We inherited Greek and Latin doublets like phlebo and veno, because doctors essentially refused to give up their traditional words.
Stubborn to the end.
Always. We navigated through Galen's 1,400-year-old misconception that left us with the word artery permanently meaning air holder. And thanks to William Harvey tying off a farmhand's arm and actually doing the math, we arrived at a precise directional vocabulary where arteries carry blood away from the heart and veins carry it back.
It is a remarkable journey of discovery, but, to leave you with one final puzzle to chew on, pulled directly from the broader context of our sources today.
Oh, I love a good puzzle.
We just spent this entire conversation proving William Harvey's revolutionary concept that the arteries and veins form one perfectly continuous, completely closed loop of blood. But the medical vocabulary also includes the root lympho, the lymphatic system. It is a completely separate one-way transport network that runs right alongside the veins, eventually draining back into them. But it isn't part of the pressurized artery vein loop at all.
Wait.
Yeah. If the cardiovascular system is a perfectly closed, watertight circuit, why do we have a completely separate parallel plumbing system pouring fluid back into it? What exactly is escaping that closed loop that requires its own dedicated drainage network?
Man, the body is always more complex than the blueprint, isn't it? Thank you for joining us on this deep dive into the language of the vessels. And remember, keep questioning the words behind the world. Catch you next time.